My name is Peter Voorhees. I'm a professor of medicine at Wake Forest University School of Medicine and the chief of the Plasma Cell Disorders Division at Atrium Health Levine Cancer Institute. And I'm talking today about kind of the evolving paradigms for frontline therapy in multiple myeloma. Before I start talking about treatment of active multiple myeloma, I'm going to first talk about a very rapidly evolving area, which is the treatment of high-risk smoldering multiple myeloma. And specifically, I'm going to discuss the results from the phase 3 Aquila trial that were presented at the December American Society of Hematology annual meeting and were published in the New England Journal of Medicine that month. So Aquila was a phase 3 study that randomized patients who are considered to have high-risk smoldering multiple myeloma to either 36 months of subcutaneous daratumumab or active surveillance. Now, they defined high-risk smoldering multiple myeloma as anyone who had at least 10% clonal plasma cells in their bone marrow and one of several different high-risk features as shown on the slide. Patients also had to have a good performance status, and the primary endpoint of this study was progression-free survival, but progression-free survival was defined as either death or progression to active multiple myeloma as defined by the Crab-Slim criteria. This is not biochemical progression. So as you can see here, with a median follow-up of approximately 5.5 years, the daratumumab arm outperformed active surveillance with regards to time to progression to active multiple myeloma or death with a hazard ratio of 0.49, so a 51% reduction in the risk of death or progression to active multiple myeloma. And as you can see in the table on the right-hand side of the slide, treatment with subcutaneous daratumumab both reduced the frequency of CRAB-related events, such as anemia and bone disease, for example, as well as the incidence of active multiple myeloma as defined by the SLIM criteria. Now, one of the criticisms of this study has been the fact that the definition of high-risk smoldering multiple myeloma was quite broad. And obviously, the way we define high-risk smoldering multiple myeloma has evolved over time. And since 2018, we've adopted an updated Mayo Clinic criteria for this entity using the 2220 criteria. So specifically, if you have more than 20% clonal plasma cells in your marrow, if your M spike is more than 2 grams per deciliter, if your affected to unaffected serum free light chain ratio is more than 20, those are all the risk factors. So if you look specifically at those patients who have 2 or more of those criteria, you can see that the daratumumab arm still outperforms active monitoring with a hazard ratio of progression-free survival of 0.36. And again, this is progression to active multiple myeloma or death. This is not just biochemical progression that we're talking about. It is interesting in this PFS curve, though, over the first year of monitoring, there is, a very similar shape to the curve, suggesting that there are some patients, perhaps in this mix, that may, in fact, have biologically active multiple myeloma. And I think over time, we're going to have to do a better job of teasing out which patients those exactly are. Now, one of the criticisms and one of the things that was discussed at the ODAC for this particular study was the clinical significance of progression-free survival in the smoldering multiple myeloma space. So you've got a condition where the patient has no symptoms. What is the clinical value of reducing the risk of progression to active multiple myeloma, especially if you're just preventing progression to, say, SLIM criteria or a drift downwards of your hemoglobin, for example. So one of the key secondary endpoints of the study is overall survival. And, both groups are clearly doing well from an overall survival perspective. But what you can see here is when you look 5 years out, 93% of the patients in the daratumumab arm are still alive, in contrast to 87% for those in active monitoring. So it's not the formal statistical analysis plan for overall survival, but but nonetheless, the ratio for survival was 0.52, and the p-value does not cross 0.98. The 95% confidence interval does not cross 1, so this was statistically significant. So moving on to newly diagnosed active multiple myeloma therapy. And first, I'm going to talk specifically about patients who are fit and potentially candidates for upfront autologous stem cell transplantation. So many of the folks in this audience are familiar with the phase 2 randomized study Griffin, and then more recently, more familiar with the phase 3 randomized study Perseus. So both of these studies were randomized trials that looked at, induction therapy with bortezomib, lenalidomide, and dexamethasone with or without daratumumab, followed by transplant, and then subsequent 2 cycles of consolidation therapy post-transplantation with either VRD or VRD plus daratumumab. Patients then were transitioned to maintenance therapy. If they were in the control arm, they just received lenalidomide single agent maintenance. If they were on the experimental arm, they received at least 2 years of daratumumab in addition to their lenalidomide. In the Griffin study, they stopped the daratumumab after 2 years. In the Perseus study, you only stop the daratumumab after 2 years if you are in a complete response and MRD negative, and you actually have the option of re-adding the daratumumab into the maintenance therapy if the patient experienced relapse of their disease. And what you can see is that the data with regards to progression-free survival from these 2 studies are virtually identical. So the hazard ratios for progression-free survival are 0.45 and 0.42 for the Griffin and Perseus studies, which is really quite remarkable. And when you look 4 years out, the progression-free survival in the quadruplet arm for Griffin is 87%, and in the Perseus study, it's 84%. I will point out that that is the best progression-free survival that's ever been reported in any randomized studies for frontline therapy of newly diagnosed myeloma patients. So really exciting, and it clearly speaks to the fact that the addition of daratumumab into the VRD backbone is beneficial in this group of patients. So looking at standard risk and high risk cytogenetic patients that were enrolled in the Perseus study. So this was a subsequent analysis that was presented at our IMS meeting in September of last year. And what you can see here with regards to progression-free survival, whether you had standard risk or high risk cytogenetic disease, you did better if you were assigned to the quadruplet arm. I will point out too, though, that the patients who got the quadruplet who had standard risk disease did do better than those who got the quadruplet who have high risk disease. And when you look at, again, at the 4-year progression-free survival, for those patients who got the quadruplet who have standard risk cytogenetics, you're looking at a progression-free survival of close to 95%, which is really quite remarkable. So daratumumab is not the only CD38 antibody that's been evaluated in this patient population in the upfront setting. So isatuximab has also been evaluated in this space as well, and the GMMG HD7 study is a good example of this. So this was a phase 3 study that looked at bortezomib, lenalidomide, and dexamethasone induction therapy with or without isatuximab for 6 cycles, followed by autologous stem cell transplant for younger, fitter patients with newly diagnosed disease. There was a second randomization after recovery from stem cell transplant where patients were assigned to either lenalidomide alone or isatuximab with lenalidomide, and I'll talk more about that later. The primary endpoint of the first randomization was achievement of MRD negativity at 10 to the minus 5 level of sensitivity. And what you can see here is that that was achieved in 50% of the patients receiving the quadruplet. That's after 18 weeks of induction therapy, in contrast to just 35.5% for those receiving the triplet. More recently, again at the American Society of Hematology meeting this past December, updated data from the first randomization were presented, including progression-free survival. And what you can see here is that progression-free survival is superior for those patients who receive the quadruplet up front relative to the triplet. Now, the hazard ratio in this particular study is not as robust as what we saw in Griffin and Perseus, zero point 0.7 specifically, but that is confounded by the second randomization where patients were either assigned to lenalidomide or isatuximab and lenalidomide. And then again, looking at patients, with high risk features, whether that's defined by ISS stage, normal versus high LDH, or cytogenetic risk, you can see that the quadruplet is outperforming the triplet in each of those groups. So again, suggesting that the addition of a CD38 antibody to the VRD backbone in an upfront transplant setting is beneficial not just for those with standard risk disease, but for those with high risk disease as well. So, updated results from the ISKIA study were presented at ASCO and EHA in June. So, the ISKIA study was a phase 3 trial that looked at carfilzomib, lenalidomide, and dexamethasone with or without isatuximab. Patients received 4 cycles of induction therapy, an upfront transplant, 4 cycles of post-transplant consolidation, and then 12 additional cycles of KRD light consolidation, again with or without isatuximab. And this particular analysis is looking at sustained MRD negativity achieved for 1 year or longer. And this is MRD negativity at 10 to the minus 6 level of sensitivity. And what you can see here is that for those patients that received the quadruplet throughout the course of their therapy, over half of the patients achieved sustained MRD negativity at 10 to the minus 6, in contrast to just 38% for those receiving the triplet. And when you look at a variety of different patients with high-risk disease features, whether that's defined strictly by cytogenetic risk or by revised or revised squared ISS staging, you can see that the quadruplet is outperforming the triplet with regards to sustained MRD negativity. And it'll be very interesting to see how this all plays out with longer follow-up with regards to progression-free and overall survival. But generally speaking, sustained MRD negativity tracks very nicely with progression-free survival in previous randomized studies in multiple myeloma. So now I'm going to pivot to newly diagnosed patients who either were not eligible for transplantation or elected to defer transplant. So there's 2 key studies in this particular area evaluating quadruplets versus triplets for this patient population. There's the Cepheus trial, which looked at daratumumab with bortezomib, lenalidomide, and dexamethasone. And then there's the IMROSE study, which looked at isatuximab with bortezomib, lenalidomide, and dexamethasone. Now, the eligibility criteria for these 2 studies were different. So for the Cepheus study, your frailty index had to be less than 2, and transplant deferred patients were allowed on this particular study. In fact, a little over a quarter of the patients in the Cepheus study were, in fact, transplant deferred but eligible. So a less frail patient population. For the IMRO study, you could be transplant ineligible only. Transplant deferred was not allowed in this particular study. That said, transplant ineligible was defined as age 65 or older, and we know that there are patients that are older than 65 who are good transplant candidates, so that has to be taken into consideration. So with all of that in mind, what you can see here is that the 4-drug induction strategy clearly outperforms the triplet with regards to progression-free survival. And again, the hazard ratios for progression-free survival are almost superimposable. So you have a hazard ratio of 0.57 in the Cepheus trial and a hazard ratio of 0.6 in the IMRO study. And then if you again look out at the 48-month or 4-year progression-free survival, with the quadruplet, you're looking at about 70% in both of these studies, which is really quite remarkable and clearly better than the triplet. But it's not as good as what we saw, in the previous studies that I showed you, the GMMGHD7 studies, Griffin and Perseus studies. So there is incremental benefit to that upfront transplant. But nonetheless, this is really strong data, different patient population than Griffin and Perseus, so I should be careful about that, but really supporting the use of quadruplet therapy for patients who are either considered transplant ineligible or elect to defer that upfront transplant. Now, One of the criticisms of both the Cepheus and the IMRO studies has been, well, this is great. You compared it to bortezomib, lenalidomide, and dexamethasone as the triplet, but increasingly we're using CD38 antibodies with lenalidomide and dexamethasone in this patient population. So what is the value add of the bortezomib into the quadruplet? And this is where the benefit study that was conducted by the IFM group comes into play. So this was a phase 3 study conducted again by the IFM that looked at the combination of isatuximab, lenalidomide, and dexamethasone with or without bortezomib. And the way that they conducted the study, they gave 12 cycles of initial therapy, followed by maintenance therapy thereafter. For those patients that were assigned to the quadruplet arm, they received bortezomib on days 1-18 of cycles 1 through 12, and then they just received it on days 1 and 15 for cycles 13 through 18. Now, the primary endpoint of this study was MRD negativity at 10 to the minus 5 level of sensitivity after 18 cycles of therapy. And what you can see here is that there's a doubling of MRD negativity, 53% with the quadruplet relative to the triplet of 26%. So the addition of bortezomib into the CD38 Lendex backbone clearly had a notable impact on MRD negativity. And the same holds true if you're looking at MRD negativity at 10 to the minus 6 level of sensitivity, again, nearly doubling, the rate of MRD negativity. Now, median follow-up is relatively short on this study. You're starting to see some divergence of the progression-free survival curves in this particular trial, but nonetheless, at the 24-month mark, both groups of patients are doing well, with progression-free survival of 85% for those receiving the quadruplet and 80% for those receiving the triplet. So, this is all well and good, but as I pointed out before, some of these patients that were in the Cepheus study were transplant eligible, and the same could be said for the IMRO study as well. So what about patients who are truly frail? So this is a subset analysis of the IMRO study, which looked at a modified International Myeloma Working Group frailty score that was based on age, the modified Charlson Comorbidity Index, and ECOG performance status. And if you had a frailty score of 0 or 1, you were considered non-frail. If your score was 2 or higher, you were considered frail. And in this particular study, approximately 30% of the patients, both in the triplet arm of the study as well as the quadruplet, were considered frail. And what you can see here is that progression-free survival was superior with the quadruplet versus the triplet, whether you were frail or not frail. I think the other thing that's important to note here is that patients who are frail did worse than the patients who are not frail. So if you compare how the non-frail patients did with the quadruplet versus the triplet, you can see that there is a difference in progression-free survival. The same holds true for the triplet. So the bottom line is that frailty does have an impact on prognosis, but the quadruplet outperforms the triplet in the frail patient population. And then when you look at, toxicity, safety, and quality of life, what you can see here in this particular slide is that patients who received the quadruplet versus the triplet were no more likely to discontinue therapy because of adverse events. They were no more likely to develop a grade 3 or higher treatment emergent adverse event. And they were also no more likely to have a grade 5 treatment averse adverse event compared to those receiving the triplet. I will point out again, though, that if you compare frail to non-frail receiving the quadruplet, there is a difference in the rates of adverse events. So patients who are frailer, do experience more treatment emergent adverse events than those that are not frail. But with regards to the quadruplet here versus the triplet, there is no difference in the frail population as far as those events. And then when you look at quality of life with the quadruplet versus the triplet, as measured by the EORTC QLQC30 index, you can see that there's absolutely no difference from those patients receiving the 4-drug combination versus the 3-drug combination. So, this is an interesting data set and suggests that you can use, a quadruplet in frailer patients recognizing that some of the doses may need to be modified, depending on what the comorbidities a patient may have. So now I'd like to talk about MRD adapted therapy for newly diagnosed myeloma patients. And I'm going to set the stage by talking about the MASTER study. So this was a single arm phase 2 study that was conducted in the United States that took patients with newly diagnosed myeloma, and they received 4 cycles of daratumumab with carfilzomib, lenalidomide, and dexamethasone induction therapy, and then that was followed by an autologous stem cell transplant. Now they could receive an additional 4-cycle cassette of dara-KRD, yet another 4-cycle cassette of dara-KRD, followed by lenalidomide maintenance. Now, MRD testing was done after each of those points. So after induction, transplant, and after each of the 2 4-cycle cassettes of consolidation therapy. And if you were MRD negative at 10 to the minus 5 level sensitivity 2 consecutive times, you stopped therapy. And what you can see here on the right-hand side of the slide at the top is that those patients who had 0 or 1 high-risk cytogenetic abnormality did remarkably well with regards to progression-free survival, but those patients who had 2 or more high-risk cytogenetic abnormalities clearly did not fare as well with regards to progression-free survival. And at first glance, everyone was like, oh my gosh, you stopped, treatment in these high-risk patients based off of MRD way too prematurely. You should have just kept the heat on the disease and kept going. But we did the same kind of analysis in the Griffin study. And again, this is a randomized phase 2 study that applied continuous therapy to these patients. So we did not stop based on MRD negativity in that particular trial. And what you can see here is that the patients who had 0 or 1 high-risk cytogenetic abnormality did really well with regards to progression-free survival, but those who had 2 or more high-risk cytogenetic abnormalities did not fare well, and they fared almost identically to those patients in the MASTER trial. So it wasn't really a matter of the fact that they stopped therapy. It was really a matter of the fact that these are just really high-risk patients, and we need a new treatment paradigm for this group of folks. But again, the MASTER is not a randomized trial. And at the most recent ASCO meeting and EHA meeting, and also published in the New England Journal of Medicine, we have the initial results from the randomized phase 3 MIDAS trial. So this is a study that was conducted by the IFM, which used an MRD adaptive platform for treatment of newly diagnosed patients. So patients with newly diagnosed disease received 6 cycles, 24 weeks of isatuximab with carfilzomib, lenalidomide, and dexamethasone. And then the randomization occurred after that based on MRD status. So if you were MRD negative after induction therapy, you either got isatuximab KRD for 6 additional cycles, or you were randomly assigned to an autologous stem cell transplant, followed by 2 post-transplant ISA KRD consolidation cycles. If you were MRD positive after induction therapy, you were either assigned to a tandem autologous stem cell transplant or a single autologous stem cell transplant followed by 2 post-transplant consolidation cycles of ISA KRD. And what you can see here is that, in the after induction therapy, MRD negativity was 63%, for those patients receiving ISA KRD. And when you looked at MRD negativity at 10 to the minus 6, it was 47%. Now, looking on the right-hand side of the slide, if you look at, the rates of MRD negativity after induction therapy versus before maintenance therapy, so this is after patients receive their assigned consolidation strategy, you can see for those that were MRD negative that were assigned to either transplant or a longer course of ISA KRD, there is absolutely no difference in the rates of MRD negativity looking at after induction or before maintenance therapy. And when you look at those patients that were MRD positive after induction therapy, it didn't matter that they got a tandem stem cell transplant. Their MRD negative rates were no better. In fact, they were a little worse than those patients who got a single stem cell transplant and 2 cycles of ISA KRD post-transplant consolidation therapy. Now, this is just a single point in time. So it'll be very important to see what sustained MRD negativity looks like in this trial and how that will translate into potential differences in progression-free and overall survival. But this suggests that you may be able to forego a transplant if you're MRD negative after a course of quadruplet therapy and just replace the transplant with a more extended course of that quadruplet therapy. And it certainly, I think, dispels the need for a tandem stem cell transplant for those patients that are persistently MRD positive after their initial induction therapy. So we've talked a lot about CD38 antibodies, daratumumab and isatuximab. One of the challenges that isatuximab has had, not only was it second to market, but it's an intravenous infusion. Now, there's a lot of good data now, showing rapid infusions that could be administered safely. So that has helped narrow the gap a bit. But nonetheless, daratumumab is overwhelmingly given as a subcutaneous formulation, whereas isatuximab is given IV. So what about subcutaneous isatuximab? And the Heraclea study was a phase 3 trial that looked exactly at this. So this is a phase 3 study that's looking at intravenous isatuximab with pomalidomide and dexamethasone, or subcutaneous isatuximab with pomalidomide and dexamethasone for patients with relapsed multiple myeloma. Now, the subcutaneous isatuximab was given at a flat dose of 1,400 milligrams, whereas the IV ISA dose was dosed at 10 milligrams per kilogram. The dosing schedule is exactly the same between the two arms of the study. And interestingly, the subcutaneous isatuximab is delivered using an on-body delivery injector, or OBI. And you can see what this looks like on the bottom left-hand side of the slide. So this is a really neat trick, hands-free way of delivering isatuximab subcutaneously. And what you can see on the upper right-hand side of the slide, the primary endpoint of the study was overall response rate. And what you can see here, there is absolutely no difference in overall response rate, whether patients got IV or subcutaneous isatuximab with their pomalidomide and dexamethasone. And a key secondary endpoint was the rates of very good partial response or better. And you can see here there is absolutely no difference in the rates of those deeper responses as well. They also wanted to look at the patient experience with this on-body injector. So they did surveys for those patients receiving intravenous isatuximab versus subcutaneous isatuximab. And when you look at the intent to treat patient population, you can see that the patient experience was more favorable for those receiving subcutaneous isatuximab versus IV. And if you restrict your look to those patients who actually completed the questionnaire, there's clearly a significant difference in satisfaction between the subcutaneous and IV preparations of isatuximab, with nearly 97% of the patients reporting either satisfactory or very satisfactory experience with the on-body injector. From a toxicity perspective, there was less infusion reactions with sub-Q preparation versus IV, 1.5% versus 25%. There was a slightly higher rate of grade 3 or higher neutropenia with sub-Q versus IV dosing at 85% versus 74%. So now I'm going to pivot to CD38 monoclonal antibody-based maintenance therapy. And I want to talk about the ARIGA trial. So this was a randomized phase 3 study that took patients who had received at least 4 cycles of induction therapy, followed by an autologous stem cell transplant, and were within 12 months of the start of their induction therapy. They had to have achieved at least a very good partial response to their induction therapy and transplant, but they had to be MRD positive at 10 to the minus 5 after recovery from stem cell transplant. And the other thing that's important to note about the study is that patients could not have received prior CD38 antibody induction therapy. Patients were randomly assigned to either receiving lenalidomide, single-agent maintenance therapy, or the combination of daratumumab with lenalidomide, and patients received maintenance therapy for up to 36 cycles. And the primary endpoint was conversion from MRD positivity to negativity at 10 to the minus 5 level of sensitivity, with secondary endpoints including progression-free survival and the usual suspects. So this was the data that was presented at our IMS meeting this past September. And as you can see here in the intent to treat population, the rates of MRD conversion to negativity was far higher in the Dara-Len arm versus the Len arm, 50.5% versus 18.8%. And whether you're looking at patients who are strictly in complete response, whether you're looking at the MRD evaluable patient population, or whether you're looking at sustained MRD negativity in patients achieving a complete response, the two-drug maintenance outperformed lenalidomide with regards to conversion to MRD negativity. And not surprisingly, this has translated into improvement in progression-free survival. So with a median follow-up of 32 months, the progression-free survival was superior for those receiving Dara-Len versus Len alone, with a hazard ratio of 0.53. So 47% reduction in the risk of progression or death with the two-drug maintenance therapy. Now, more recently at the ASH meeting in December, a subset analysis was conducted looking at outcomes for patients with high-risk disease. And whether you define high-risk disease by the new International Myeloma Society criteria for high-risk myeloma, whether you're looking specifically at those patients who have deletion 17p, whether you're looking at patients who have high-risk IGH translocations with a gain or amplification of 1q21, et cetera, you can see here that the rates of MRD negative conversion are higher with the two-drug maintenance versus the one-drug maintenance. And whether you look at it, by the number of high-risk cytogenetic abnormalities, again, everything favors the two-drug maintenance versus the one-drug maintenance. And the same can be said with progression-free survival as well. Now, the confidence intervals here are quite broad, but the trends are pretty clear. And that is whether you're standard risk or high risk, the two-drug maintenance does seem to be outperforming lenalidomide with regards to progression-free survival as well. I think the challenge with the ARIGA study is the fact that patients were not allowed to have a CD38 antibody as part of their induction therapy. So the question is, can you extrapolate these results to those patients who have received CD38 antibody therapy as part of their induction? And the accurate answer is that we really don't know yet, but at least we can kind of glean some potential answers from the Cassiopeia study. So recall Cassiopeia was a phase 3 study that looked at daratumumab with bortezomib, thalidomide, and dexamethasone, followed by transplant, for patients with newly diagnosed myeloma. And importantly, in this particular study, after induction therapy and transplant, patients were randomly assigned to either observation or daratumumab monotherapy as maintenance. And what you can see here on the right-hand side of the slide, so this is a median follow-up from the second randomization of 70.5 months. So this is long follow-up here. So if you look at those patients who did not get DARA as part of their induction therapy and got DARA in maintenance versus those that did not get DARA in induction and were observed and got no maintenance therapy, there's a dramatic difference in progression-free survival with a hazard ratio of 0.34. But when you look at those patients who got the quadruplet up front, followed by their transplant, the impact of the daratumumab on outcomes with regards to progression-free survival are not as dramatic. That said, with long follow-up, there is a difference in progression-free survival, which is statistically significant, but the hazard ratio is only 0.76. So the addition of the CD38 antibody in maintenance was beneficial whether you got DARA in the induction or not. But, clearly for those that did not get the daratumumab in their induction therapy, the addition of the DARA to the maintenance made a dramatic difference. So just to kind of conclude, I would argue that quadruplets are the new standard of care for patients with newly diagnosed myeloma. I do think that triplets remain an important standard of care. Recognize that, these studies did not look at patients who are 80 years of age or older, and there are also frail patients that are under the age of 80 that need to be defined in our studies. I think that the best progression-free survival outcomes that have ever been reported in myeloma are in those studies that looked at quadruplet therapy with upfront transplants. So there is an incremental benefit with regards to PFS when it comes to that upfront transplant. I think the impact of MRD adapted consolidation on progression-free survival and overall survival outcomes remains to be determined. The question is can you de-escalate if you're MRD negative, and is it beneficial to escalate if you're MRD positive? The MIDAS study tells us that you may be able to omit a transplant, but again, I think we need sustained MRD negative data and progression-free survival data to really answer that question. I think that daratumumab and lenalidomide maintenance is a new standard of care for patients who are MRD positive after their induction therapy and transplant, but largely for those that have not received a CD38 antibody induction strategy. I think it remains to be seen what the value add of the CD38 antibody is in maintenance therapy for those that have received a quadruplet up front. And the GMMG HD7 study has that second randomization to either isatuximab and lenalidomide or lenalidomide. So that will really help us answer the question. So the first case is a patient with smoldering multiple myeloma. So this is a 78-year-old man who was screened for a clonal plasma cell disorder as part of a workup of cardiac amyloidosis. So their CBC and chemistries were normal. They had a monoclonal IgG kappa spike of 2.2 grams per deciliter, so it's more than 2 grams per deciliter. They had a serum free kappa light chain level of 290 with a free light chain ratio of 31.6, so greater than 20. They had 40% clonal plasma cells in their bone marrow, so greater than 20%. So again, going to the 2018 Mayo Clinic criteria for high-risk smoldering myeloma, they have all 3 high-risk features. You only need 2. So this puts them in the category of high-risk smoldering multiple myeloma. And what that means is that the likelihood of them progressing to active multiple myeloma in a 2-year time frame is approximately 50%. As far as cytogenetics are concerned, the patient had a gain of 1q21 and a trisomy 9. Now, interestingly, there is data that hyperdiploidy, we think of hyperdiploidy in active multiple myeloma as a favorable risk feature. In the smoldering myeloma space, if you're hyperdiploid, that actually is a risk factor for progression to active multiple myeloma. So while hyperdiploidy, you'll do well with treatment with active multiple myeloma in the smoldering myeloma space, it does suggest that you're at somewhat higher risk. Now, interestingly, in this particular case, an endomyocardial biopsy was pursued, and you might ask, well, why would you do that? The patient has myeloma. This patient has AL amyloidosis, complicating their myeloma diagnosis, right? Well, as it turns out, this patient had wild type TTR amyloid, so they had senile amyloidosis with cardiac manifestations. And there was a couple of reasons why a decision was made to look at this. One, patients with TTR amyloidosis, their congestive heart failure is typically not as symptomatic as those who have AL amyloidosis with cardiac involvement. And this patient's functional status was still relatively preserved. And the other thing, too, is that they really had no other manifestations of AL amyloidosis. So there was just some red flags that perhaps there were 2 processes going on. And again, the biopsy did confirm wild type TTR amyloid. On imaging, the patient had a PET CT and MRI of the spine, which showed no bone lesions. It's absolutely critical that smoldering myeloma patients get advanced imaging, whether it's with PET CT or MRI imaging, doesn't matter, or low dose whole body CT. It's key because skeletal survey is not sensitive enough to look for early bone lesions of multiple myeloma. For this particular patient, their comorbidities included diastolic heart failure. They also had pretty significant neuropathic pain in their distal lower extremities related to pretty significant lumbar spine stenosis. 1 year into observation, so initially we elected to just monitor this patient, and 1 year into active monitoring, the M spike has increased just a little bit. It's 2.5 grams per deciliter now. The serum free kappa light chains have increased just a bit from 290 to 312 milligrams per liter, and the free light chain ratio has crept up a little bit as well. In spite of the comorbidities, the patient's quite active, likes to work out on their elliptical, likes to go walk in the neighborhood, and has a performance status of 1, but does have edema related to their diastolic heart failure and does have chronic dyspnea with exertion related to that. So the question is, do you treat this patient or not? And, I think that the decision-making process for treating smoldering multiple myeloma, even with the phase 3 Aquila data in hand, is a very nuanced discussion. And it's really, truly key to do shared decision-making in this situation. So you have to acknowledge, some of the limitations of the Aquila data, and you also have to acknowledge, the fact that a lot of patients that were treated on Aquila, did not go on to receive, what we would consider modern induction therapy for active myeloma subsequently. So this overall survival advantage that has been discerned in the Aquila study has been called into the question. Nonetheless, in this particular patient's case, I think to myself, how easy is it going to be to treat this patient with a 3-drug or 4-drug therapy? Um, if they go on to develop active multiple myeloma, they have heart failure, so the dexamethasone and lenalidomide components of therapy are likely going to exacerbate fluid retention issues. So that has to be considered. And the patient has very significant neuropathic pain in their lower extremities related to this lumbar spine stenosis. So bortezomib is going to be a challenging drug to administer as well. The patient is in their 70s, so if we delay, we're not necessarily preventing progression to active multiple myeloma with single agent subcutaneous daratumumab, but we're significantly delaying it. And when you look at time to next treatment, it's significantly improved in the daratumumab arm versus the active surveillance arm. So, can we run out the clock on this? Can we treat this patient safely with a single drug and avoid having to expose this patient to the challenges of 3 and 4 drug therapy? And that's exactly the discussion that we had, and we elected to go for it. So he was started on single agent daratumumab. He had some exacerbation of edema and dyspnea with exertion with the first 2 doses of daratumumab that we really thought were due to the corticosteroid pre-medication that he was getting. And what we've done for patients that are very steroid intolerant and even Benadryl intolerant, we will remove the pre-medications from daratumumab after the first couple of doses. And that's exactly what we did here. And the patient has had no more problems with exacerbation of fluid retention ever since. Their dyspnea has reverted to baseline, and the patient essentially has no symptoms of their daratumumab therapy, and they are now in a partial response. The plan is to stop therapy, assuming that they're continuing to tolerate it well and they're continuing to respond to it, 36 months into therapy. But so far, we're off to a good start, and I think we're hopefully going to achieve exactly what we sought out to do in the first place.
That's really a great case. And, this idea of sort of pushing out the time where they might need more definitive treatment. Also, maybe by the time he ends up needing treatment, a bispecific is going to be part of first line or something else will be out there that's going to be easier.
You're absolutely correct. And, that's oftentimes what I discuss with patients, so if you kick that can of definitive therapy down the road, we may have a bispecific antibody combination approved in the front line. We may have CAR T cell consolidation after induction therapy approved at that point, so and that's actually the argument that I make for upfront transplant as well for a patient with newly diagnosed active myeloma. That longer progression-free survival may be the difference between a CAR T cell therapy being approved or a bispecific combination being approved in first relapse or not.
Absolutely. How about this 57-year-old woman?
All right, so this is a 57-year-old woman who presented with highly symptomatic bone disease, symptomatic anemia with hypercalcemia and acute renal failure. Hemoglobin was 8.5 at presentation, calcium was 14.8, Creatinine was 1.56. The beta 2 microglobulin was off the charts at 9.7. She had an IgG kappa M spike as well at 4.8 grams per deciliter, free kappa light chains of 6,750 milligrams per liter, and a free light chain ratio of 2,045, 80% involvement of their marrow space with multiple myeloma, and on FISH testing had a deletion 1p, which is not considered high risk in isolation in the modern era. Now, if deletion 1p is associated with additional high risk IgH translocation or gain of 1q21, then yes, it is considered high risk. Or if you have biallelic deletion of 1p32, that is considered high risk. So this patient is technically not considered high risk by cytogenetic testing, but this patient's clearly behaving in an aggressive, their disease is behaving in an aggressive manner. And the cytogenetic profile is really one of hypodiploidy, which is typically associated with worse outcomes. So, I do think that this patient is behaving, with fairly aggressive disease biology. Imaging showed innumerable FDG avid lytic bone disease, no extramedullary involvement, thankfully, and very limited comorbidities. Their performance status is only a 2 in spite of them being 57, but that performance status of 2 is really due to the disease itself and not because of any comorbidities. This patient is just incapacitated with bone pain, is really unable to do any work, because of that. So we placed this patient on daratumumab, bortezomib, lenalidomide, and dexamethasone based on the Griffin and Perseus studies showing the advantage of this quadruplet over VRD for patients who are transplant eligible. Now, this patient perhaps surprisingly developed fairly early emergence of symptomatic neuropathy going into the second cycle of induction therapy. So we elected to take out the bortezomib and replace it with carfilzomib based on, very favorable data with both daratumumab and isatuximab, with KRD for newly diagnosed patients as well. And as we know, carfilzomib has a much better neuropathy signal than bortezomib does. So she went on to receive a total of 4 cycles of quadruplet therapy, the latter 3 incorporating carfilzomib instead of bortezomib. And she was in an MRD positive, very good partial response after induction. We did elect to pursue an upfront transplant for this patient, young, wanted to improve that progression-free survival, really to get the most out of that frontline therapy, and was concerned about the fact that they had ISS stage 3 disease at initial diagnosis, as well as that deletion 1p32. So she underwent that upfront autologous stem cell transplant, did quite well, and was in an MRD negative complete response after recovery from transplant. We did go on to treat the patient with 2 cycles of post-transplant consolidation. And this is an important point because, we don't do that much in the US. And, my point has always been, if you're going to replicate the results of these studies, you should try and stick to the script, assuming the patient is tolerating the therapy well, and whether you're looking at Griffin, whether you're looking at Perseus, these patients got 6 cycles of therapy around their transplant. It just so happened that 4 of them were before transplant and 2 of them were after transplant. If you look at the MIDAS study, they got 6 cycles of induction therapy before being randomized based on their MRD status. If you look at Ischia, they got far more, cycles of induction and consolidation than any of those studies. So, we oftentimes just do those 4 cycles in transplant and we're done. But, there's no randomized data suggesting that that is a equally effective strategy. So we did, again, especially given the high risk nature of the patient's disease at diagnosis, we did the 2 cycles of post-transplant consolidation, and we continued lenalidomide and daratumumab maintenance. And the plan is to continue that daratumumab and lenalidomide maintenance therapy for 2 years. If they're still MRD negative, we will take the daratumumab out and we will continue lenalidomide maintenance thereafter. Now, in this particular patient's case, she's not tolerating lenalidomide great. There's a fair amount of fatigue. There's a lot of brain fog that patients will describe on IMiD therapy. And we've already gone down to a 5 milligram dose. So, If we get to that 2-year mark and we're still struggling with lenalidomide-related side effects, we may elect to stop the lenalidomide and continue the daratumumab thereafter. So we'll just have to see how that plays out.
So that's a great case. I'm just kind of curious, how often do you have people developing neuropathy on bortezomib where you switch to carfilzomib like you did in this patient?
I would say that it's uncommon. So unlike the Griffin and Perseus studies where bortezomib was given twice weekly for the first 2 weeks of the induction cycles, I think all of us in clinical practice administer the bortezomib weekly in the induction therapy, and that does tend to mitigate some of the neuropathy that we see, with bortezomib. So my typical experience is that patients may start to experience some bortezomib neuropathy going into cycle 3 and cycle 4. It's usually low grade. We oftentimes don't have to adjust dose or hold dose under those circumstances, and we're able to treat through. And once they get onto maintenance therapy, a lot, if not all, of the bortezomib related neuropathy symptoms tend to fade away. So it's uncommon. I would say maybe 5 to 10% of cases at most. Now, if somebody has bad baseline neuropathy, whether it's from diabetes, or let's say they have like the smoldering myeloma patient, who had terrible lumbar spine stenosis with neuropathic pain in their legs, or maybe they have a tumor in their spine, that's caused cord compression. They've got neuropathic pain symptoms related to that, or foraminal nerve root compression that persists even with response to therapy. I typically will use carfilzomib, based quadruplet therapy in that group of patients instead of bortezomib, really to lessen the risk of exacerbating that pre-existing neuropathy.
Interesting. How about your last patient, the 73-year-old man?
So this is a 73-year-old gentleman who similarly presented with rapidly escalating bone pain, and specifically thoracic bone pain. The hemoglobin was 11. Calcium and creatinine were largely normal. Beta 2 microglobulin here is only 3, and the LDH is normal. The M spike is 2.3 grams per deciliter. The free kappa light chains are 583 milligrams per liter with a free light chain ratio of 61. The burden of disease on a bone marrow biopsy was just 15%. They had an 1114 translocation and deletion 13q. When you look at the PET CT, there were innumerable FDG avid lytic lesions, and this poor patient had compression deformities involving T5, T6, T8, T10, and T12, and they were almost bent 90 degrees as a result of the thoracic kyphosis, resulting from these innumerable thoracic compression deformities. So in addition to the severe morbidity that this patient was suffering from their multiple myeloma, they also had a long-standing diagnosis of Parkinson's disease. So this patient's actually had Parkinson's for approximately 20 years and is on Cinemet for it, but perhaps remarkably has been fairly stable, over many years of follow-up, and is quite cognitively intact, but does have the masked faces and some of the issues, as far as their gait is concerned. They have a low risk early stage prostate cancer that's just undergoing active surveillance, and the PSA has been very stable. This patient's performance status is absolutely terrible. When I'm first meeting them, in fact, we had to hospitalize them because of the amount of pain they were in. And I would say that their performance status was at best a 3. But again, this was all related to what was going on in the thoracic spine for this poor patient. So as far as, this person, terrible performance status, frail, but largely frail due to their disease, but also with Parkinson and not high-risk disease features. So we decided that an upfront transplant perhaps was not in this patient's best interests. Again, we had that discussion, and the patient was in agreement with that recommendation. We did, given the fact that the myeloma was making the patient so symptomatic, we did elect to do quadruplet induction therapy despite the performance status of 3, despite the Parkinson disease. So they got DVRD induction therapy. And after the first 4 cycles of treatment, they're in a very good partial response. We also did kyphoplasty on a couple of those compression fractures, given the degree of pain that the patient was having at initial presentation, which really helped quite a bit. So this patient's performance status has improved dramatically. I would say it's a 1 at this point, and it's improved so much that we've elected to collect stem cells at this point, really as an insurance policy for the future. We still plan to forego an upfront transplant. Again, we've had that discussion again. While an upfront transplant does improve progression-free survival, you can use it at relapse, and there's no difference in overall survival with a upfront versus deferred transplant approach. So that's the way that we've decided to do this. So our plan is to basically treat him as was done in the Cepheus and IMROSE studies, where we'll give 6 cycles of 4-drug therapy, and then we'll follow that up with daratumumab and lenalidomide until disease progression or the emergence of unacceptable side effects. But I will say that this patient is tolerating therapy beautifully. And unlike the last case that I told you about, there's been absolutely no neuropathy thus far.
Just kind of curious, if you did an MRD assay and it was negative, would you consider holding therapy?
It's a great question. I think we need randomized data to really inform that decision. There's a nice study that was done out of the University of Chicago where they stopped maintenance therapy, for those that were in a stained MRD negative status. But it was a very heterogeneous patient population. Patients had been on maintenance therapy for as little as 1 year to as long as many years. There were patients that were initially started on multi-drug maintenance and then went on to single agent lenalidomide. So it was a very heterogeneous patient population. And the other thing that they did is they were able to look at MRD negativity at 10 to the minus 7 level of sensitivity. And we don't have the ability to do that right now in routine clinical practice. And when you looked at those patients that were not MRD negative at 10 to the minus 7, but were negative at 10 to the minus 6, they didn't do as well from a progression-free survival perspective when you stop len maintenance therapy. And most of the patients were MRD positive at 10 to the minus 7, but negative at 10 to the minus 6. There's a nice study out of Greece that looked at patients with sustained MRD negativity, complete metabolic response by PET-CT, stopping maintenance therapy after 2 years, and their initial data look really good. Progression-free survival looks excellent. That said, it's not randomized. So would they have done even better, had they just stayed on maintenance therapy? So for a patient who's tolerating maintenance therapy poorly, absolutely yes. I will look at their MRD status, and if they are MRD negative, ideally someone who's been on maintenance therapy for at least 2 years, if they're MRD negative, I will stop maintenance therapy. But it's really driven by symptoms at this point. I think that the SWOG 1803 study, the dramatic trial, will really help us understand whether, stopping maintenance therapy based off of MRD results is the right thing to do.
So, every now and then I get little flashes from other parts of oncology, and I just got a flash in my brain about something called the EMBARK study in prostate cancer. You probably never heard of it, but it was the use of hormonal therapy in PSA only relapse. So in prostate, that's all they have is the PSA, and they treat these patients. In the past they would give them, LHRH agonists and all these other things now. And this study, they did it intermittently. They would when the PSA went down to 0, they would stop and just wait for it to come back up, and then they would treat again. And I know it's obviously a completely different disease, but I kind of wonder whether someday myeloma will evolve into that, type of, since you're kind of dealing subclinical with a marker, basically, can you sort of, particularly, of course, prostate, they have more symptoms, a lot of side effects from treatment, but similar concept.
One of the challenges that we have now is, when is the right time to intervene again? Do you do it at MRD relapse? So from MRD negative to
Right.
MRD positive, do you wait to biochemical progression? What is the right way to do it? and that we need randomized studies to help us address those questions. I think, once we get blood-based MRD testing that's reliable, I think that those studies will be a lot easier to do. I think right now they're difficult because, the best MRD assays that are clinically available are bone marrow based, and patients are not going to
Right.
want to go through repeated bone
Right.
marrows to see whether their MRD status has changed.